Assalamualaikum dear students, my name is Dr. Hira Shaukat and I am your course instructor of Integumentary Physiotherapy. Because of some technical issue, my camera is not working unfortunately since last day, and I'm trying my best to fix the issue, but as you know, because of this lockdown situation, as the shops and the technical support is not available, so I'm not able to still to fix this issue. So that is why we have to conduct another lecture without a video. But I am trying my best to to speak aloud so that you may be able to hear the lecture easily. Alright. So let's start with the today's topic. And the today's topic is diabetic foot ulcer. As you know that after the mids, when we started the course, right after the mids, we started the types of ulcers, and the ulcer that we have studied so far, they were the first one we discussed about the arterial ulcer, which was related with the peripheral arterial disease. Then we discussed about the venous ulcers, which was related with the venous insufficiency and some other factors. So today we are starting a very important but a very significant healthcare problem ulcer, that is the diabetic foot ulcer. So before starting the diabetes or the diabetic foot ulcer, obviously all of us know that diabetes has been a growing problem nowadays. It's a very significant health problem worldwide, and the incidence of diabetes occurrence is, it is increasing with the passage of years. A number of every when you talk about any race, when you talk about any nation, the incidence of the diabetic person, it is increasing. It is running in the families. It is because of a number of risk factors and because of a number of other things. Diabetes is, the number of diabetes, the prevalence and the incidence of diabetes is increasing day by day. Obviously, this is known as the mother of disease, so it has a number of complications, a number of side effects, and one of the most common complication and one of the most common side effects associated with the diabetes mellitus is diabetic foot ulcer. So we are starting today with the diabetic foot ulcer. What is a diabetic foot ulcer, and how this is important to to be aware about the regular foot examination in the diabetic persons, and what are the etiology and the risk factor for the foot ulcers in the diabetic person. We will summarize all these things in the today's lecture. So let's start with the today's topic. As you know, let's first of all we will see the learning the learning objectives. So the learning objectives for today's lecture are: first of all, we will see the definition, then we will discuss about the etiology and the risk factors of the foot ulcers. Afterwards, we will go through the pathophysiology. Then we will see the clinical presentation of the patient who has problem of diabetic foot ulcer. Then we will see the classification of diabetic foot ulcers. Afterwards, we will see the the diagnostic criteria or some other investigations which will be helpful in the diagnosis and treatment of the diabetic foot ulcer, and finally the management of the diabetic foot ulcer. So what is the definition of diabetic foot ulcer? Obviously, the diabetic foot ulcer will be, the ulcer is always a non-healing or poorly healing wound. So a diabetic foot ulcer is defined as a non-healing or poorly healing break in the skin, which is commonly present below the ankle in the patient with diabetes, and this is critical in the natural history of the diabetic foot. All right, so the basic criteria must be the person must be diabetic, and the ulcer must be present on the anatomical location, which must be below the ankle in most of the cases. All right, so this is a definition of the diabetic foot ulcers. Good. All right. Diabetic foot ulcer is a major complication of the diabetes mellitus and probably the major component of the diabetic foot. It occurs in 15% of people with the diabetes mellitus and precedes 84% of all the diabetes related lower leg amputations. Okay. Obviously, we have, all of us, we have idea that there are two types of diabetes mellitus, type 1 and type 2, and sometimes we discuss also the gestational diabetes mellitus in this category. But usually we are concerned always with the type 1 and the type 2 diabetes mellitus. Type 1 diabetes mellitus is basically the insulin dependent diabetes mellitus, while the type 2 is always the non-insulin diabetes, non-insulin dependent diabetes mellitus. Okay, and the type 2 diabetes mellitus, this is always a heterogeneous disorder for which specific secondary genetic causes and some other metabolic syndromes are being identified. And type 2 diabetes mellitus is usually seen in the older adults, while the type 1 is most common uh, among the young generation, and some in the even it is present in generally in a lot of cases. All right, so we are discussing the diabetic foot ulcer. So always remember the diabetes is the single most common underlying cause of the lower extremity amputation in a lot of countries. Okay, and the foot problems are always there, the most common complications of the diabetes mellitus that can lead to the infection, that can lead to a difficulty in walking, and a lot of complications are there because of that thing. Okay, and if there will be the amputation, then there can be the risk of re-amputation. So what to do, or there can be the risk of contralateral limb amputation as well. So what to do, how to manage the risk factor, let's see in the upcoming slide. So the risk factors, if we talk about the risk factors, obviously there are a number of risk factors that can lead to the foot ulcers. There can be some local factors, there can be some systemic risk factors that can lead to foot ulceration and amputation. So all of these factors must be considered in the prevention and in the treatment of diabetic foot. Okay, and always remember the strongest and the easiest um, risk factor that can help you to identify the presence of ulcer or amputation uh, due to some due to this diabetes mellitus, I must say, is always some abnormal skin changes or some biomechanical abnormality. So you have to undergo the foot examination, the lower limb examination regularly. If you are diabetic, or if one of your family person is diabetic, so all of you must know how to evaluate the risk factors by yourself, how to get clue about the risk factors. And if you are not able to get clue about the risk factor, then you must know that when at one time I have to approach some clinician, or I have to approach some endocrinologist or diabetology. So among the risk factors, a lot of risk factors are there. There can be some neuropathic causes, there can be peripheral vascular disease, there can be abnormal foot pressure, there can be persistent hyperglycemia, there can be some history of trauma. So there can be some deformity, foot deformity, or some altered joint biomechanics. There can be limited joint mobility. There can be previous history of ulceration or amputation, or some family history of ulceration, and duration of diabetes. That means that you are having diabetes since long, you are having an older age, or you are having a poor vision that can lead to some injury to your foot. So these are the risk factors. There is no need to to go in the details of the risk factor, because obviously you are the students of the final semester, so you have studied all the risk factors in detail in the previous lecture, in the previous semester. So let's discuss the next slide. So the etiology, the basic pathogenetic mechanisms involved in diabetic foot complications are: number one, they say is the neuropathic, number two is the angiopathic, and number third is the infection. Always remember that these factors can always lead to the foot complication, including the foot ulcer formation. So if you talk about the neuropathy, always remember this is a very common thing that we all know, that diabetes always affects your sensory supply, your motor supply, and your autonomic supply. So in patients with the sensory neuropathy, pain, it will be the initial sign or the symptom. So these are the factors through which you can have an idea about the symptoms that can lead to, eventually that can lead to some abnormality related to the foot complication. Okay, and there is a concept, always remember, which is known as the lobes is actually the loss of protective sensation. So loss of protective sensation means there is some sensory normality. So you have to go in the detail and discuss about the loss of protective sensation in the diabetic patients. Next, there can be ischemic changes. There can be some angiopathic things, angiopathic factors that if there is poor blood supply leads to poor healing of the wound, and poor healing of the wound can lead to prolong the chronicity of the wound, and that can eventually it can lead to the ulcer formation if you don't take care of your wound very well. And there can be either there in the third on the third there can be any kind of infection. So always remember this kind of infection. This is a very much common that can lead to the ulceration. How the infection can be converted into the ulceration, we have discussed this thing before the meds, with how the ulceration and the infection they are related to each other, right? So pathophysiology just focus on the factors. If there is neuropathy, just see the cursor with me. If there is neuropathy, obviously the three things will be very evident. Will be the loss of protective sensation, lobes. There can be some foot deformity or joint rigidity, or there can be some dryness in the skin or decrease integrity of the skin. All right. So these three signs will be there: the loss of protective sensation, foot deformity, or the changes in the skin will be visible. All right. And these things can lead to what? Loss of protective sensation will lead to the unnoticed repetitive trauma. Okay. The foot deformity will lead to the improper loading and abnormal plantar fresh pressure. And the joint skin, if the joint skin is not integrated, or joint skin is dry or is having very rash changes, then it will lead to the cracks and the fissures and in the skin, which eventually will be open up, and then they will be converted into some kind of acute wound, and eventually they can lead to the ulcer formation. Okay. So these are the things related to the neuropathy. These can be the support mechanism of your ulcer formation of the diabetic wound. Then, if you talk about the peripheral arterial disease, obviously the ischemia can lead to the ulcer formation or through the abnormal wound healing, and this ulcer formation will eventually lead into the necrosis of that involved area, and that necrosis can eventually lead into the infarction of the ganglion. Okay, and eventually you have to go for the amputation. All right. There can be some other factors related to this: lack of education to the patients, lack of food protective sensation, lack of education to the healthcare providers, lack of lack of a person is not able, or he is not having, he or she cannot afford to visit a diabetologist or endocrinologist. The patient is always barefooted, or the footwear is improper. So all of these things can lead to, eventually they can lead to the some wound, or some eventually they can cause some infection. So these are the factors, and this is very important slide there, because this is showing you the suggestive mechanism. So I must say that this slide, although this is a one single slide, but this is showing a lot of mechanism. This is showing a lot of mechanism of injury that can eventually lead to the diabetic foot ulcer, right? And one thing they are adding over here, that is there can be sometimes osteoarthropathy or the Charcot foot, which can eventually lead to the some foot deformity, and which it can in turn leads to the foot amputation in the very later stage. All right. So this is the pathophysiology. You have to focus on the neuropathy and what are the associated changes. You have to discuss the peripheral arterial changes and the resultant change, and you have to go through the infection and some other things. All right. So these are the factors you have to memorize when you have to prepare for your exam. So what will be the clinical presentation of the patient? If we talk about the history, obviously, first of all, the systemic disease will be the diabetes mellitus. If you take the history, there will be onset and progression of the ulcer. There can be some constitutional symptoms. For example, there can be fever. If you go for the physical examination, there will be presence of your abnormal wound or some chronic wound or some ulcer. If you talk about the neuropathic wound foot, then the foot is always warm and well perfused with palpable pulses. Sweating is diminished, and the skin may be dry, or it can be prone to some fissuring or some open changes, or some abnormal creases, which will be like they will be. It will be obvious that they can be opened up if the skin dryness will be you know persistent. Or you can go for the neuroischemic food. Obviously, in the neuroischemic food, there will be the temperature will be low, there will be pulseless feet, the skin will be thin, shiny, and without hair. There will be also the atrophy of the subcutaneous tissue or intermittent claudication, and the resting pain may be absent because of the neuropathy. So these are the common symptoms. You have to ask the patient if you want to rule out the cause, the possible cause of the diabetic foot ulcer in the diabetic, like in the diabetic patient. Okay. Okay. So just see the diagram. All of these are the diabetic foot ulcers, abnormal wounds in the diabetes mellitus patient. They're saying that they are the neuropathic feet with plantar ulcer surrounded by the callus formation. Okay, this is a callus formation. Okay, and this is the ulcer over the medial aspect of the first metatarsophalangeal joint of the neuroischemic foot. So this is the, the diagrammatic representation of the diabetic ulcer. Okay, so how to do the ulcer examination? You have to go through the location of the ulcer. You have to, because this ulcer examination, we will fill the wound assessment chart that we have discussed in the chapter number 5. So you have to see the location, you have to see the size, depth, margins, color, order, base, floor, and is there is some kind of abnormal discharge from the wound or not, and attempts made to express pus or not are there. What is the type of ulcer? Is it neuroischemic in nature? Is it ischemic, or is this neuropathic? So you have to go for the specific symptoms. Then probe to look for extensions into bone, sinus tract, joint, and tendon sheet. You have to go through the grading of the wound, that either this is superficial right now or if this has been converted into something deeper. All right. Probe hitting bone signifies possible underlying osteomyelitis. Obviously, if the bone have been converted into the deep wound, then there will be chance of the involvement of the bone as well. Okay. And when the bone is exposed, the patient is assumed to have osteomyelitis and improvement otherwise. So, but this is a very later stage. Uh, and how the grading is done, this will be discussed in the upcoming slide. Then comes G, the vascular changes. You have to check about the pulses. How we will check the pulses? I have added a video already. What will be the capillary return? You have to press that area for around 2 seconds or more than 2 seconds, and if it returns less than in 2 seconds, there is a normal capillary return. You have to go for the color changes. Is there some kind of abnormal redness or abnormal blueness? Changes of ischemia, is there skin atrophy, or there is some kind of nail atrophy, or there is some abnormal wrinkling or diminished pedal hairs. If you see some any kind of abnormal changes, then you have to check for the neurological signs. You can use the tuning fork with the 128 hertz frequency, and you can place, actually you have to just strike the tuning fork on the specific lines of your feet through, in order to just have an idea about the vibration testing. So what we do, we take a 128 hertz tuning fork, and we will place the lower strand of the tuning fork on the upper part of the on the dorsal on the dorsal part of the foot. I will add that picture over here. ओके, जस्ट आपने इसको फेरना है पैर के ऊपर की तरफ, नील से नीचे जाते हुए ऊपर, पहले टो पे, सेकंड टो पे, थर्ड पे, फोर्थ पे एंड सो ऑन. ठीक है, ताकि आपको वाइब्रेशन का अंदाजा हो जाए. फिर आपने क्या करना है, नेक्स्ट इज द हाउ टू evaluate the sensation of the pressure and the touch. So for that we need a monofilament, and when we will take the monofilament, we will place the monofilament on the altered position on the plantar side of the foot. You can place the monofilament on the first, third, and the fifth digit on you, or you can place it on the metatarsal head. You can place the uh, that that monofilament on your midfoot medially or laterally, or you can place the monofilament on the dorsal aspect of the midfoot. All right. Then you can go for the pinprick sensation. You can use some sharp object. You can use the tip of the pin, or you can go for the temperature perception. Either the person is he feeling hot or cold or not. So this is how you can assess the protective sensations and the protective vibrating sensation in the patient suffering with the diabetes mellitus and the diabetic wound. So this is how in the monofilament testing You have to check first, third, and the fifth toe here in the metatarsal head, then in the midfoot, and then on the heel. So these are the area you have to undergo in order to assess the protective sensation with the monofilament. You can also use it here. Okay, so this is the monofilament testing. Then comes the musculoskeletal deformities. Always see is there any abnormality in the musculoskeletal, the biomechanical factor. Attitude and posture of lower extremity must be checked. Orthopedic deformities are there or not, which involves the bunions, hamartoes, Charcot deformity, amputation, etc. So you can go for those. Limited joint mobility, you can check by asking the patient to move the ankle and the toes, and you can check even the tender HLS contracture. Okay. Then comes the evaluation of the skin and the nails of the toe, because this is one of the most comprehensive part of the examination. Skin appearance must be checked, either this if there is some specific color, texture, texture, quality in dry skin, and we will continue after that as well. Alright, so let's resume. So you can go for there some abnormal callus formation. Is there some heel fissure? You can check is there cracking of skin or not. You can check the nail appearance of the person. You can check check the presence of here some abnormal ulceration, some infection signs, or either there is the interdigital spaces are normal and they're having an Indian or not. So these are the things you can go in the examination of skin and nail in the person in which you're assessing the diabetic. But all right. So how to classify these wounds? We are using the Wigner's classification, University of Texas classification. This is the one of most common classification which is used to grade the diabetic foot ulcer, and these have been already discussed in the orthopedic surgery as well, but let's revise over here. In the vaginal classification, what we see there are six grades. Grade 0 say there is the pre-ulcer state, there is no open lesion, but there can be some deformity, all right? In the grade 1, they say there is superficial ulcer and there is disruption of skin without penetration of the subcutaneous fat layer. In the grade 2, there is full thickness ulcer which is penetrating through the fat to the deeper tissue. In the grade 3, there is deep ulcer with the abscess formation. And the grade 4, there is gangrene. And in the grade 5, there is gangrene. The gangrene have been generalized now, or this has involved the extensive area. So when you move downward towards the grade 5 from the grade 0, then the wound becomes deeper and deeper, and eventually it is involving your bone and then becoming the gangrene from the bone. All right. So just here, look here, grade 0, no ulcer formation. In the grade 1, very superficial with the involvement of your the outermost layers of the skin involving the epidermis and the dermis. Then it is involving your, you know, after the hypodermis and the fatty area, then the muscle involvement, the bone involvement. All right. So this is how. you can discuss the Witner's classification. This is a University of Texas classification for the diabetic wound. How they do grading, they say that in the grade 0 there is no epithelialization. Grade 1 of the wound says there is superficial wound. Grade 2 says there is deeper wound to the which has involved the tendon and the capsule of the joint. And grade 3 says that the wound has involved the bone or the joint. So this is how grading or staging of wound is done. All right, so this is how the University of Texas also classified it. So now, how to do the workup for this thing? How to go for the workup for specifically for the diabetes, and how to do the workup for the diabetic foot. So in the biochemical factors, you have to go for the blood sugar testing. You have to go for the HbA1c, which is basically the hemosylated hemoglobin. You can go for the complete blood count. You can go for the ESR test. You can go for the C reactive protein in order to assess the inflammation and the infection status. And you can go for the wound and the blood culture as well in order to assess the type of infection. You can go for some imaging. You can go for some x-ray if you need. You can go for vascular investigation or some neurological investigations according to the requirement, and you can go for the assessment of the feet as well. If we talk about the imaging, then in the imaging you can go for the x-rays, you can go for the AP view, lateral view of the feet and the ankle. You can go for the MRI, but only if it is indicated or if prescribed by the dermatologist. If you have to differentiate abscess from the soft tissue swelling, you can go for the bone scan. If you have to differentiate between the soft tissue infection, and you have to differentiate between the involvement of your bony tissue. Okay, so this is how imaging can help always. And if you want to go for the vascular testing, then in the vascular testing you have to evaluate the extent of occlusive vascular disease, or occlusive the status of the peripheral or the venous involvement in the assessment of healing potential. If you are suspecting some low extremity ischemia, then obviously you can go for the Doppler test. You can go for the ABI status, and how these tests will be performed we have discussed in the arterial ulcers, where we discuss the peripheral arterial disease. So you can even go for the toe pressure measurement, that is the in which you can go for you have to measure the pressure here, but ABI is done very commonly. So, any abnormal results of the above investigation, the presence of non-healing foot ulcer, they suggest a vascular assessment in detail, and determination of distal runoff and the perfusion can be assessed by arteriography. You can go for some detailed angiography, or you can go for some magnetic resonance angiography according to the prescription. All right. So this is how you can use handheld Doppler with sphygmomanometer to measure ankle slip pressure. All right. So this is how you can measure the ABI. You can measure the brachial pulses, or and along with the Doppler. And here you can measure the posterior tibial artery and dorsalis pedis artery pulses along with the Doppler. So this is how you can measure the ABI, right? So this is a complete picture of ABI, and I have told you the detailed procedure of ABI measurement in the arterial ulcer. So this is how you can measure the toe pressure. All right. So just have idea, and this is here where the electrodes have been placed. So, and if we talk about the assessment of plantar foot pressure, then obviously high plantar foot pressure have been identified as a significant risk factor for ulceration. Always, always. Measurements are to be done regularly as important changes in distribution and level of pressures and diabetic neuropathic feet occur, which occur during a relatively short period. So Harris-Matt and computer technique, they always allow qualitative and quantitative measurements of the plantar foot pressure respectively, and through this we can identify the potential area of the ulceration. All right. So this is how the Harris-Matt and the computer technique can be used. Okay. This is how you can go here, like this. All right. So this is how you can measure. You can assess the plantar feet pressure distribution. Okay, one of the most important thing which which must be done regularly whenever is needed, but on the priority basis. If we talk about the management section, obviously you can go for the debridement if there is infection. You can go for the surgical management to reduce or remove bony prominences and to improve soft tissue coverage. If you want to go for the conservative approach, then you can go for the proper wound care, or you have to work for the reduction of the plantar pressure. You can go for specific vascular management of ischemia. You can go for the medical management and some prevention of the risk factor or the controlling of the risk factor. And the most important, you have to reduce risk of the recurrence of the diabetic foot ulcer. So let's discuss these categories in detail. If you want to go for debridement, obviously debridement will be done only in cases of the when the ulcer or the wound is having no potential for healing by its own, then you have to go for the surgical type of debridement of the infected wound. Alright, so we have discussed the types of debridement in the detail before the merge. You can go for the wound care. In the wound care, what you can do, you can go for the specific wound care using the bandages and using the dressings. You can, but the aim of dressing must be that it must provide moist environment, it must absorb the exudate of the wound, it must act as the barrier between the external environment and your wounds, and this must offload pressure at the ulcer point. Always remember, so these characteristics must be present in the dressing if you are allowing the patient to wear a dressing, or the diabetologist or the the surgeon is asking him to, or the surgeon is putting applying dressing around the wound. Okay, types of wound care products are there in which you can go for. Here I will upload a number of videos I have related to the types of the dressing, so I will upload all of those. So you must go for the types of the dressing, and according to that, the indicated dressing, the patient will be advised to wear, or to buy the specific dressing. Okay, the most important part, how to do offloading, and always we know that offloading is that how we can reduce the plantar pressure at the site. So in the diabetic patient, we must know how to reduce the pressure to the maximum pressure point. Foot ulcer, this reducing the trauma to the ulcer and allowing it to heal. Okay, what can be the method? The most common gold standard method is always a total contact cast. You can go for the non-void wearing condition. You can use some foot cast or boots. You can use removable walking braces with rocker bottom soles. You can go for some orthosis, or you can use the wet shoes. You can use some healing sandal or with insole, or you can go for the accommodative bracing. Okay, so these are the available options which you can go, and the specialized orthopedician or the orthotics and prosthetic specialist can advise you that you must go for this device, or or this orthosis for the offloading. So you must consider all these points as well. How to do the vascular management of ischemia? Obviously, vascular management of ischemia has been discussed in the peripheral arterial disease section. So they say that vascular supply to the affected limb should be assessed early, and if there is impairment, then the vascular reconstruction surgery or the visit to the vascular surgeon is always advised. Okay, and how to do the surgical management to reduce or remove bony prominences. Then a structurally deformed foot may give rise to the high pressure areas causing ulcer that do not heal with offloading treatment or therapeutic footwear. Then such type of deformities, they are treated surgically to affect healing and to prevent recurrence. And examples are always correction of hematose, excision of exostosis, bionions, and tender Achilles lengthening, but that depends upon the choice of the orthopedic surgeon. Okay, Ji. Then they say diabetic foot infection, what we can go. In the foot ulcer, there will be deep and the overt uh, chances of the limb involvement. In the foot infection, there will be necrotizing fasciitis and the gangrene. Alright, there will be if you talk about the organism presence, there will be the gram positive with the polymicrobial presence. The litis from us ulcer, they can be more than or less than 2 centimeter. If you talk about the osteomyelitis in the limb, there will be a presence of the osteomyelitis in the later stages. If we talk about the clinical features, the person will be ill, will be having the symptoms of the sepsis, the involvement of the infection to the other body organs, or the involvement of the blood. In the ischemia, there will be presence of ischemia, vascular calcification, or the visit to vascular surgeon will be important. And hospitalization will always be required if the limb has been undergone the threatening condition because of involvement of the extensive risk factors. Okay, so these are the factors you must consider. These are the pictures always. This goes this as this. One, two, three, four, like this. One, two. This is the gangrene. Okay. So local signs of wound infection, generation tissue becomes increasingly friable, base of the ulcer becomes moist and changes from the healthy pink granulation to the yellowish to the grayish tissue. Discharge changes from clear to purulent and unpleasant odor is there the signs of the deep infection. Okay, we have discussed in the nerves and the skin section already. What to do for the non-limb threatening viscose? Obviously, the patient is diabetic and there can be contralateral limb involvement in the later days as well. So, in the case of the non-limb threatening, what my points was we must consider. These patients are initially managed as outpatients and hospitalized only. And when no improvement is noticed after 48 to 72 hours or the condition deteriorates and antibiotic therapy is commenced and if ulcer is present, antibiotic therapy will be advised. Okay, then even you can go for the cleansing or the debridement of the ulcer, and then ulcer management is always followed up. You can go for the hyperglycemic management, and you have to the control the other risk factors as much as you can. And the response to the treatment is then reevaluated after 48 to 72 hours, and necessary action may need to be taken. And the patient education and preventive measures, pediatric care, they are the most important factors if you want to uh, prevent or minimize the threats to the normal limb. Okay, and obviously in the limb threatening condition we have gone through the detailed um, management in the last slides. You can go for some surgical management, you can go for the wound care, you can go for the antibiotic therapy, medical management of the comorbidities. And what kind of antibiotics can be advised? The always empirical antibiotics will be prescribed for the patient, because empiric therapy for severe infections, they will be the broad spectrum, so they will be given intravenously in the case of the infection. But in the case of the minor infection, they can go for the narrow spectrum antibiotics. Okay. So this is about the antibiotic therapy. You can just go through this slide. And 1 to 2 week course for mild to moderate infection antibiotic therapy. They can go more than 2 weeks for more serious infection. And if there is involvement of the bone as well, and the wound has been entered into the deep stage, then you can go for the 6 to 8 weeks or the more longer course of the antibiotics. Okay. You can go for the repetitive test involved, including the WBC count or the CBC, ESR, some other inflammatory markers. You can go for blood sugar control, must be there. Other metabolic parameters they have to check out. Okay, Lexin, ampicillin, and celestine they are the, and the tobramycin and the clindamycin they are the options they can go for. All right, so they also are given the options vancomycin and then metronidazole and clindamycin, etc. They are the alternative choices for the antibiotics. So, how to do prevention of the diabetic foot ulcer? Patient education is always very much important. Foot care, the regular foot examination by the patient or some family member must be there. Even you can go for some podiatric care if you don't have idea how to do the foot care. Therapeutic shoes you can use. Reduction of plantar pressure is important. Surgery is a lot. Will be recommended in the later stages. Multidisciplinary approach. This is always involving the diabetologist, endocrinologist, orthopedician, physiotherapist, occupational therapist, or the orthotic or prosthetic specialist. So This is about the diabetic foot ulcer. This is one of the most important topics. A number of details this topic is covering. Still, if you want to ask any question, then you can ask me. But this is one of the most important topic, not only from paper point of view, but also from your professional point of view. Because in the clinical field, in your practice, you will see a lot of patients presenting to you with the complaint in the feet, with the pain complaint in the of the pain or pulselessness or the temperature changes or the skin changes in the feet, and how to educate the patient and how to guide them and how to make them aware about the complication of the diabetes. This is very much important. So anything you want to ask, you can ask me anytime. Thank you so much.